Good afternoon. My name is Dr. Rebecca Bascom, and I'm a pulmonary physician at Penn State College of Medicine in Hershey, Pennsylvania. My topic today is mast cells and respiratory breathing difficulties in EDS. By way of disclosures, I do have funded research through the Patient-Centered Outcomes Research Institute, PCORI, the National Institutes of Health, the Penn State CTSI, and participate in clinical trials related to lung diseases funded by a variety of pharmaceutical companies. So let's get started. You've heard of mast cells, of course, and they do affect your respiratory health. And it's also true that there are other factors that can affect your respiratory health that you need to be aware of. So my talk is not going to focus solely on mast cells in respiratory health, but those connections and also other ways that I, as a respiratory physician, think about respiratory health, and to give you the tools so that you also can track your health. In this talk, I will focus on what you need to know about the respiratory system, what questions to ask yourself and your healthcare provider, and also to provide you with an idea of the personal toolkit that will allow you to monitor your respiratory health. When I speak with people with EDS, there are frequent questions that come up, some of which I've shown on this slide. Why can't I breathe comfortably? How can I tell if I'm getting sick? How can I tell if my medicines are working? Is it safe to do this or do that? How come I can't do something and other people can? Are my medicines affecting my breathing? Could a procedure that I may be facing, could that affect my breathing? And what do I do if, or what do I do when? The common thread for all of these questions is that people want to know how to manage their respiratory health. So let's spend the next while doing that. Beginning with an abridged dictionary. When I speak of symptoms, I'm describing what a person experiences. You are the expert on your symptoms. Signs are things that a clinician can observe, your breathing pattern, the effort required to take in a breath, presence of a cough, noisy breathing, perhaps differences in how your chest wall is configured. Those would all be signs. Tests are things that can be measured, and images are things that can be viewed. And I would say, by way of preamble, that some of the difficulties related to mast cells relate to the difficulties in measuring mast cell activation, for example, and how to interpret symptoms that a person is having, which may be due to mast cell activation or may be due to other factors. And one of the real important pieces of work that the EDS society is advancing is developing a common language and a consensus description through the consortium to allow people who have EDS to describe their symptoms and to then challenge clinicians to develop the means of observation and the way to develop tests that can measure what a person is experiencing. So symptoms, signs, tests, and images would be X-rays or other types of things that visualize the respiratory system. I like to think about a respiratory toolkit. I don't know if and others of you have this kind of toolkit in your home, but here's how I think about it. First and foremost is the history. We must listen to the stories and the experiences of people who have EDS and to understand their respiratory symptoms. This is, in general, a less well-developed area. If you look at many of the reports of symptoms in people with EDS, there's great focus on the musculoskeletal manifestations, the neurologic manifestations, the gastrointestinal manifestations, the autonomic symptoms. But respiratory symptoms have received relatively little focus. And so this is an area where additional work needs to be done. The stethoscope is a time-honored method of listening for respiratory symptoms. You can hear things in the deep lung crackles. You can hear wheezing when the airways are narrowed. When the mucus has built up, you can hear also crackles and a phlegmy cough. So the stethoscope is very useful. If somebody has a wheeze, a single wheeze anywhere in the lung can be transmitted and heard throughout the lung. And in contrast, if there are crackles or scarring, that will produce sounds that are heard very locally. So the stethoscope can help localize the sites of the abnormalities. Arterial blood gases are fairly painful to obtain, and so we don't use them that often, but they do provide direct measurement of the uptake of oxygen, how much oxygen is in the bloodstream, and also whether the body is getting rid of the carbon dioxide that builds up as a result of normal metabolism. And finally, the acid-base balance in the blood. So an arterial blood gas is done for that purpose. One of the real workhorses of the respiratory toolkit is pulmonary function tests. And a pulmonary function test comes in several main forms. One of the main, most common one is shown here in this red, white, and blue panel here to the right, and that is spirometry. Spirometry is done by having a person take in as deep a breath as they can, exhaling forcefully, causing a brisk rise in the flow, expiratory flow rate, and then as the air continues to be expelled, the flow rate decreases. And here at this point, the person has expired the maximum amount of air possible. At that point, the respiratory therapist will say, now take a deep breath in, and you'll suck air in like this, and the test is completed. And you can see this little loop right here that shows when somebody is breathing quietly, much less air is being moved through the windpipe. So there's tidal breathing or quiet breathing, and there's also testing through spirometry. Again, you take a deep breath in, blow out hard for at least 6 seconds. It's quite onerous. And then a deep breath afterwards, like that. One of the other things that a pulmonary function test can be used for is to look at the effect of bronchodilator medications, things that can relax the smooth muscle and open up the airway. So in this example here, you can see the red line is a little bit to the side of the blue line. And so that the red line is the test, the same spirometry test that was performed after inhalation of a bronchodilator, such as albuterol. And so what this test shows us is that there is an improvement in lung function in this example after inhaling albuterol. And this is one of the cardinal features of asthma, a condition we'll discuss in a few minutes. And asthma is often a disease associated with localized mast cell release of mediators such as histamine. Okay, pulmonary function tests, a very important part of the respiratory toolkit. And as I'll show you a little bit later on, there are now portable pulmonary function tests, either a peak flow meter that can be used that captures this point of maximum flow, is a very useful way to monitor asthma. And Also, there are more complicated portable units that are now available. Here is an example of radiography. I'm showing you here a cross-section of the thorax. Here is the breastbone or sternum. Here is the spine. Here are the white bones, the shoulder blades, muscles, and here are the black air-containing lungs. You can see air is here on the outside of the thorax, and you can also see that the lungs are mostly filled with air, with some dots that are the blood vessels that branch out and go out to the edge of the lungs to scoop up the oxygen and bring it into the bloodstream. Some people with EDS have a difference in how their sternum is positioned. It can be pressed downwards, and so the lungs cannot expand. A small amount of that, a pectus excavatum it's called, can cause a insignificant decrease in the ability to bring air into the lungs. For other people, this is more significant and can be a source of difficulty. Another thing you can see on a CAT scan, this black structure right in the center is the windpipe or trachea, and changes in the shape of the trachea can be a source of difficulty. Continuing down the respiratory toolkit, we have blood studies, including serology, looking for evidence of allergy to specific things such as pollen, or indoor things such as dust mite, pets. It can also be used to look at the ability to fight infections. Immunoglobulins can be determined using blood studies in people who've had recurrent infections. It is uncommon in EDS for tissue sampling to be needed. This is more commonly used when there are concerns about lung cancer, something that occurs typically in older years in people who have smoked cigarettes. And then cultures of expectorated or coughed up sputum, phlegm, can be used to look for chronic infections. So as you can see, the respiratory toolkit is available and is well established. The task for anybody who has EDS is to find the signal in the noise. This is a term that engineers use, signal to noise ratio. And when I think about that, I think of two common shows that were popular shows. One was called Car Talk, where people would call up and say, I hear this clunking sound. Or a show called This Old House, where someone would call up and say, there's this mysterious creaking. And the show was always about, is this sound or is this issue, is this trouble or is it just a noise? So in the setting of the respiratory system for people with EDS, signal would be important because it would be abnormal. Whereas noise in this setting would just be normal variation. We all have normal ranges. For example, in the morning, our lung function is a little lower and it improves later in the day. That's normal variation. Whereas somebody who has asthma, that variation is accentuated and may be the cause of nighttime awakening through significant dips in the lung function. So now I'd like to spend a couple minutes walking through for you the kinds of questions that I found to be useful in people who are being evaluated for respiratory problems. It starts with figuring out whether you were healthy at birth and did you go home with your mother. Those help anchor your health in the perinatal period at the time you were born. Some people were born with health problems that set the stage for ongoing difficulties. Did you begin school on time? Were there health problems with childhood respiratory troubles before starting school, an important predictor of lung growth? And then how far did someone go in school? That can also help understand exposures that related to the educational process. Physical education class during junior high and high school is a time when people begin to discover if they have respiratory limitations. In the case of EDS, sometimes this happens related to musculoskeletal issues. But thinking back and tracking PE class and whether or not there were respiratory problems is a useful thing, particularly because there's increased demand for minute ventilation, breathing rate, and also because class often happens outside in the cold, which can also be a trigger for asthma. And participation in organized sports can also uncover limitations. Social history focuses on agriculture exposure, particularly in central Pennsylvania where there's a lot of this. Childhood tobacco smoke exposure and other irritant exposures can be important in affecting the respiratory tract. And then personal tobacco history, another source of chronic respiratory problems, non-allergic. And then hobbies and travel can also result in situations that can affect lung health. And then thinking about occupational history, we ask people to track their past exposures, their military service, and past job history, and what their exposures were and how that might have affected them. In the environmental history, paying attention to a person's residence, how long they've been in the home, what the structures are, what the materials are. Dampness is a particular issue that's very important in the residential setting, as well as dust from disrupted structures. The heating system, whether or not there's a humidification system, whether it drains properly, are there filters, all of these things can impact respiratory health and are important as I, as a clinician, am evaluating an individual, and as you are creating your own personal inventory and your personal respiratory health history. If you have a particular exposure or a particular situation where there's an exposure of interest, a material safety data sheet, or SDS, is a very important source of information. And there are standardized standardized elements or components of the SDS that include health risks and how to protect yourself. Let's now speak about the upper respiratory tract, and let me orient you with this slide showing a side view. You can see this is a cutaway, and here is a person's eye, their eyebrow, the nostril, and I'd like to both show you the things that can be the source of symptoms and also structures that help protect us while we're breathing. So the first thing in the nostril, there are little hairs called vibrissae that help collect dust particles. These turbinates, then as you can see there on the side of the side wall of the nasal passages, they create turbulent airflow. And that mixing of the airflow brings the inhaled toxicants and pollutants up against the epithelium where they are taken up by the mucociliary stream, which can then help protect the lower respiratory tract from being exposed and also help clear that. It's also why the nasal passages often are the source of symptoms related to inhaled exposures. You can see here that airstream comes back here in the back. This is the larynx and the pharynx here. And one of the things that you can also see is that down here behind the windpipe is the esophagus. And that's why we'll mention at the end of this talk the importance of gastroesophageal reflux. So when stomach juice comes up the esophagus, it can spill and irritate the larynx and can cause laryngopharyngeal reflux and coughing and difficulties. So this view shows, and sorry, let me tell you one more thing about that. The GERD can also come up here by the eustachian tube and the sinuses. So people who have very severe GERD can find themselves with chronic sinus conditions, ear congestion and plugging, as well as laryngopharyngeal reflux. So, how do you track upper respiratory symptoms? There's this delightful test called the SNOT test, Sinonasal Outcome Test. I've given you a link here, and you can see here that it provides quite a range of nasal symptoms, tracking them on severity, and also having you track the things that are most important. Now, this is obviously a very long list, 22 things, but I think what you can do personally is to figure out the 5 most important nasal symptoms if this is something you're dealing with, and you can then track them on a bi-weekly basis and use them as you're trying to look at different things to intervene. One of the things that this emphasizes also is this difficulty with the overlap between different symptoms. So you can see that it's been shown that people with nasal symptoms can have difficulty falling asleep, can wake up tired, wake up and have fatigue, decreased productivity. And people with EDS are very familiar with these symptoms, and I think it remains to be worked out the contributions of the respiratory tract to these more generalized symptoms in people with EDS. I did want to show you a couple of examples of the evidence that the mast cell can be locally activated in the respiratory tract. This is old data, but was elegantly done. So what they did is they looked at people who said that when they get around cold air, their nose would run. Cold, dry air responders. And those people are in the black bars. They are challenged with cold, dry air. And you can see that with that, there is a rise, several-fold rise in the histamine level in the nasal secretions in their nose. And there's also a large rise in their tryptase. So in somebody with cold air rhinitis, their nose runs in the cold air, if you look at their nose and measure the secretions, you'll see that the histamine and tryptase levels have risen. So this is an example of non-allergic mast cell activation localized in the nasal passages. Similarly, if you take someone who is allergic to something, someone, for example, who has springtime rhinitis, and you challenge them with pollen, the pollen to which they're allergic, or if they're allergic to cats and you expose them to cats, they also will have, now this is the striped bars, will have a rise in the histamine level after challenge compared to baseline, and also tryptase. So this is an example of an allergic stimulation or IgE-mediated stimulation of the mast cell. So very clearly, localized mast cell activation can happen in the nose, and it can also happen throughout the respiratory tract. And we really think about it being a common airway with very similar reactions happening in the nose and the lower lungs. And so if one is being treated, it's very helpful to treat the entire airway, not just the lungs and the respiratory tract. So this has led studies of the pathogenesis or how this disease develops. For allergic rhinitis has been shown that intranasal steroids aimed to the side, antihistamines, oral or topical, or oral leukotriene agents all have been effective in reducing those symptoms. And then for this reflex rhinitis, whether you're someone who gets, when you eat foods or spicy foods, your nose runs, or in cold air, you can use an anticholinergic. In this study, they used atropine. The product that's on the market is nasal ipratropium. So there are specific therapies that you can discuss with your clinician that can help you manage these symptoms. For sinusitis, you can see if a person has chronic sinus congestion and pussy drainage, a CAT scan can help see what's going on. In this case, this one on the left shows these inflamed sinuses, both in the maxillary sinuses and also more centrally, sometimes needing to be treated with antibiotics, steroids, or evaluation for immunodeficiency. Another really common issue that can occur is people can have tremendous facial discomfort and pain and congestion. But here, the CAT scan can be entirely normal. All of these cavities are nice and black with very clear structures. And so for those folks, the otolaryngologists end up recommending treatment more for migraine or neuropathic pain. And then finally, a few comments about asthma. People with EDS are twice as likely to be prescribed an asthma medication. And asthma is the most common cause of lost time from school among children. So good asthma control is important. Asthma control tests, peak flow meters can all be used as part of the management plan. And the ABCs of asthma management are to do an asthma control test on a monthly basis to determine whether you are in control with your current medications, and to, with your provider, establish your management plan. There are a variety of peak flow devices that can allow you to monitor. If you're someone who has problems with laryngeal function, then a spirometer is a more useful thing in addition to just a peak flow meter. But for basic asthma tracking, a peak flow meter is fine. I'm not going to speak in more detail about other topics. I mentioned laryngopharyngeal reflux, which can be managed just with treatment for GERD. Inducible laryngeal obstruction is sometimes a mimic for asthma. Restriction due to neuromuscular factors may be a problem that a clinician can sort through, and excessive dynamic airway collapse. So I hope I've walked you through a respiratory toolkit that can help you find your way through the many questions that are posed by people who have EDS and who have respiratory symptoms, and that I've encouraged you to track your own respiratory health and to distinguish the signal and the noise, and work with your clinician to come up with a plan to monitor and manage your respiratory health. Thank you very much.